The heart's external anatomy features a base, an apex, and distinct surfaces. The apex points downward and to the left. Clinically, this is the point of maximal impulse at the fifth intercostal space. The base sits posteriorly while the sternocostal and diaphragmatic surfaces face the chest wall and diaphragm. Internally, the right and left atria serve as the heart's receiving chambers. Notice their remarkably thin walls compared to the ventricles. The right atrium collects the oxygenated blood through three main venous inlets: the superior vena cava, inferior vena cava, and the coronary sinus. Inside, we observe the rough, ridge-like pectinate muscles within the auricles, sharply contrasting with the smooth posterior wall and the central fossa ovalis. Moving inferiorly, we enter the ventricles, the primary pumping chambers of the heart, separated by the thick interventricular septum. Inside, the walls are lined with irregular muscular columns called trabeculi carnea, along with specialized papillary muscles that anchor the chordae tendineae. Notice the striking structural difference. The left ventricular wall is approximately 3 times thicker than the right. This massive myocardium is essential to overcome high systemic afterload, generating enough pressure to perfuse the entire body. 4 distinct valves ensure unidirectional blood flow, preventing dangerous regurgitation. During systole, the tricuspid and mitral valves snap shut, the chordae tendineae tense, anchoring the valvular apparatus. Simultaneously, rising ventricular pressure forces the aortic and pulmonary semilunar valves open. This precise mechanical synchronization produces the classic lopped-up cardiac sounds. The oxygenated blood returns from the body via the vena cava into the right atrium, then flows into the right ventricle. It is then pumped through the pulmonary artery, a high-yield exam point, as it's the only artery carrying the oxygenated blood to the lungs. Oxygenated blood returns through the pulmonary veins into the left atrium. Finally, the left ventricle ejects this oxygen-rich blood through the aorta to supply the entire systemic circuit. The heart's intrinsic pacemaker, the sinoatrial SA node, initiates an electrical impulse that sweeps across the atria. Crucially, this signal pauses at the atrioventricular AV node for about 0.1 seconds, allowing the ventricles to fully fill with blood. The impulse then races down the bundle of His and Purkinje fibers, triggering a powerful synchronized ventricular contraction.